Okay. Thank you. Thank you, sir. Good morning, sir.
You're welcome. Go ahead. Yes.
So I'll be taking question number 10, and Dr. Ade will be my simulator. The question reads as, a 35-year-old woman who presented with chronic cough, night sweats, and weight loss. She lives in a room apartment with her husband and 4 kids. Gene expert was positive. The tasks are: educate the patient on the risks to the family and compliance. 2, outline steps in patient's education. So I think we need a timekeeper. I don't know whether I will be giving 10 minutes on this. So Dr. Ade, are you ready?
Yes, good morning, Dr. Yaya. I'm ready.
Okay. I think we'll start. So, good morning. How are you?
Dr. Dalhatu can keep the time.
Okay. Good morning. How are you?
Yeah, good morning, doctor.
My name is Dr. Yahya Muhammad. I'm one of the candidates for these exams. I'm here to discuss with you about the risks your illness poses to your family, as well as the compliance on medication. Is that okay with you?
No problem. You can go ahead.
Can we go ahead, please?
Yeah, you can do that.
I want to assure you that whatever we discuss is going to be confidential. I'm not going to divulge the information to anyone. And again, you have the ultimate right to stop me at any time and ask me. And when we finish this discussion, you're the one to decide on what you do. Is that okay with you?
That is okay, doctor.
Okay. I learned that you're a 35-year-old.
Yes, I am. I'm 35.
And you've been having cough, night sweat, and weight loss.
That is correct, doctor.
And you live in a room apartment with your 4 children and a husband.
That's how it is now. Things are very
And there is
hard.
a result called Gene Expert. It was positive. Is that right?
I don't know the one in Guinness, but they collect blood and saliva from me, and they say the result is positive for TB.
Okay. Thank you very much. Before we proceed, I would like to ask some personal information about you. Is that okay?
Okay. It's okay, no problem.
Please, may I know your name, ma?
I'm Mrs. Johnson.
Okay, Mrs. Johnson. Where did you live?
Man like this, Mrs. Johnson.
I live at Zoo Road in Abuja.
Okay, Zoo Road, Abuja. Please, what's your education level?
Well, I couldn't finish my secondary school before I got married.
Okay, thank you. As I said again, please, were you told anything about this, your cough you've been doing, night sweat, weight loss, and the recent result for TB? How much do you know? Were you told about that?
Well, they just told me that because I have not been fine for about 3 months now, just as you have been told. And I went to chemist shop to buy drugs. It wasn't working. Before you say I should go to the hospital. The hospital, they took some blood tests and saliva tests from me. The nurse told me that I have TB after the result has come. The nurse said I should come and meet you today so that you can explain to me about the condition.
Okay, that sputum that was collected, were you told anything about that?
They say they saw TB inside the sputum.
Okay, thank you very much for this information. Do you know anything about this tuberculosis?
I don't know much about it, but I used to hear people have tuberculosis. They used to lose weight. I don't know much about it.
Okay. Do you want to know about that?
Yes, if you can tell me, that's why I'm here.
Do you want to know more, or you just want to have some superficial idea?
Anything that you think I should know about it, you can tell me, doctor.
Okay. This tuberculosis is an illness that is caused by an infection. And that infection, we have several things that cause infection. We call them bacteria. And among the bacteria, the one that specifically causes this tuberculosis is called Mycobacterium tuberculosis. So it's a bacterial infection caused by Mycobacterium tuberculosis. We get this infection by inhalation of particles of this organism that are spread in the atmosphere. If somebody have the disease and cough, it's expected several of particles of this bacteria is released in the atmosphere. And when one inhales, he has chance of becoming down with the disease. especially if there are soldiers that fight against infection in human body. So if someone has deficiency or weakened form of those soldiers that we call immunity, he can easily get that infection and it will proliferate in the body. And the target place for this bacteria, Mycobacterium tuberculosis, is the lungs. And that's why you've been having cough. As you see, you have cough for a long time. And other symptoms from the lungs. However, it's not only lungs that this Mycobacterium affects. It can go to the brain, to the liver, to the heart, to the kidney, to the skin, and all other parts of the body, causing variety of symptoms. And how to know whether somebody is infected with that is by taking the sputum, just like your own that was taken, and do a test that is called gene expert, which your own is positive. And even if it's not positive, it can be considered to have, one may consider that to have that infection. So there are other investigations that will be done to make sure other systems are okay before somebody is commenced on medication. And the medications are usually 4 initially, subsequently will become 2. And if it is only pulmonary, meaning affecting the lungs, you will take the drugs for just 6 months. However, if other organs are affected, could be as 9 months or 1 year. And one need to take this medication judiciously for those period of time without a single day missing of the dose. And this drug, fortunately, they are free. They are easily accessible. But just like other drugs, they may have 1 or 2 side effects. And if one has that side effect, you can come to the hospital. Could be some visual impairment, could be yellowness of the eye, could be change in coloration of all your fluid like urine, saliva. So, but there are effective systems to take care of that. And evaluation before giving this drug may reduce this side effects. And some of these side effects may warrant changing the pattern of the medication. And some you just need to be assured and continue with the medication. Can you please recap what I said?
Doctor, you have said many things. So, like I remember you say the condition na bacteria, one mycobacteria they cause am, and it can affect somebody's lungs and some other part of the body also. And you say there's a treatment. I have to take drug. Initially, you take 4 drugs. Later, you take 2 drugs, and the drug too has a side effect. That's what I can remember from what I've seen.
Thank you very much. I really remember most of what I said. To go ahead with how this disease poses a risk to your family, we need to understand some 1 or 2 things. As I said, for those like your own, that they culture this bacteria called Mycobacterium in your sputum. So you have high chance of transmitting this disease to your family. And that is one of the reasons I'm here. So the reason, and you also live in single apartment with your husband and children. So the more closer you are, it is also a risk that this disease will be transmitted to your family. And depend on number of windows in your family, in your room, and those and air circulating. And again, depends on whether you are using protective covering, what we call face masks, and also depends on the number of cough you've been doing and whether you cough freely in the room or you get to another site in the room and in a container. So all those things. And again, those soldiers I said in your family members, if they are strong. If they are less strong, it's also a risk. It makes this disease to easily spread to your family. So I don't know, can you just tell me how the nature of your room? Is it closed room with windows or how it is?
The room is a one small room like that too. And it just we have one. Before we were living in a 2-bedroom apartment until my husband lost his job. So it's his friend that just gave us this small room to manage. And we have been there for about 6 months. 6 months.
So how long did you stay with your family?
Yes, my husband and my 4 children, all of us were living in that same room.
Or every day, or sometimes they went somewhere and come back? How much averagely in it?
Where would they go again now? We are a family, we are staying together.
Okay. So do you cough freely in the room?
I used to cough, especially at night.
Okay. So Mrs. Johnson, I want to tell you that all these things, they poses high chance of transmitting this disease to your family. So, meaning I will advocate some advice for you. 1, if there are other rooms in the family, in the house, you need to get to one room and stay for a very particular time. Or if you have close relative around, we may need to arrange with them so that you go to one of them and leave, unless if there is something reasonable for you to communicate with your family. And again, sometimes we even have to take somebody back to the hospital to spend at least first 2 weeks. That is when there is high chance of transmitting this disease. Again, your family members and you must be wearing protective covering like a face mask. And if you want to cough, you shouldn't cough freely. You may have a container. You go to a separate place and cough and close the container. So all those ones, they help. Again, we may need to test your family members. In case if they don't have the disease, we may consider giving them some medication that reduce this risk of getting this infection from you. And you must be taking your medication. If you take your medication, it protects you and your family. You easily get cured of the disease, and the chance of transmitting to your family is reduced. Can you please recap what I said?
Okay, doctor, you have told me that this disease, it can contact, my people too can be infected. That's my family member. That I need to, if I can get a separate room to go and stay, or if I can be admitted to be on treatment. And he equally told me that if I take the medicine, the condition, the TB will get cured, and I will not be able to infect my family members. But my problem now is, how will I be able to? I can't get any room to go and stay.
Okay,
This one, somebody
I
just
want to
said me
start
now.
addressing your concerns. You said you don't have any place to stay.
Sorry,
That's what
30 seconds left.
Okay. If I advocate coming to the hospital to spend 2 weeks and communicating with your family, unless when there is need, is that okay with you?
There's no doubt. That one is better for me now. So
Okay.
far, I can
Meanwhile,
get.
okay. Any other concern?
My concern is I don't want my little baby. I have a baby of about 5 years old. I don't want him to be infected with this condition.
I
Time
want to
up.
assure you, Mrs. Johnson, that if you follow all these, wear face masks, taking you to the hospital, and you judiciously take your medication, the risk of infecting not only your 5-year-old, all other members of the family will reduce. Any more concern? In view of the time is off, I would
Time
like to
up.
give you my phone number. I would like to give you some pamphlet. I would like to give you some website that will add more information to you. And don't hesitate to call me whenever you want to ask an information from me. So we'll meet subsequently and arrange and continue from where we stop. Thank you very much, Mrs. Johnson. Thank you.
It's okay, doctor.
I
Thank you.
wish you all the best. I wish you quick recovery. Thank you.
Thank you, doctor.
So these are some of the steps I followed. I'm going to the second question, outline the steps in patient's education. So whatever we do, there are steps to follow in order to do well. One of which is steps in educating the patient. Education of patient is one of the cornerstone of the treatment these days, as patients should be taken along with their disease. So one, we have to assessing the learning needs. There has to be an assessment that there is need to patient need to be educated. And again, we have to developing a learning objectives. Whatever we do, not only educating a patient, we may have to have an objective so that we reflect back to see whether we have achieved those objectives later. So planning and implementing patients' education, we have to plan and implement. The planning including, okay, how are we going to follow, which methods, where are we going to stay, and some other things necessary. Then the teaching methods we are going to employ. Which language are we going to communicate? Is it only patient himself or with one of the caregiver or the family? So this has to be, then teaching materials. Sometimes we may use a tool to show a patient how something is done. Or sometimes we may need to use some videos or practical demonstrations for that. Then subsequently, we may need to evaluate what we have done, whether those objectives we have highlighted above, we have achieved them. Then documentation, this is very, very important because we may decide to carry a stride how much of our patients are being educated about the disease. So without documentation, we may not be able to actually do that. And again, it helps in subsequent, if another team or somebody part of the care team is going to add something, okay? is different from somebody that has been documented, being educated about the disease that somebody has not been. So you know where to start with. And again, it may also help in assessing back subsequently. Okay, let me assess back whether the patient still retain the education given to him. So those are the steps in patient education. So I just have 3 or 4 slides about health education. It's a vital component of all 3 levels of prevention: primary, secondary, and tertiary. Patient education is an integral part of the treatment and care, especially for the long term. Even the short-term diseases, patients need to be educated and carried along, but more so for the long-term disease. It is a multi-professional and intersectoral teamwork and includes networking. So what are the objectives of this patient education? There are many objectives, but I think these are some of the important ones. We want to increase the knowledge of factors that affect the health. Like this, our index patient, we need to do more because the danger she poses on her family. She has a younger children, the husband and everything, and they are at high rates of being affected with this disease. So we have to identify those factors that affect their health. Then we have to encourage behaviors that promote the health, just like some of the things I've highlighted for her that may reduce this spread of this disease. Encourage use of appropriate health services, especially preventive services, and inform the public about advances, their uses, and limitations. The public may not be aware of some recent advances in healthcare, but through patients' education, they will be aware and some of the limitations. Sometimes patients may expect something that is not possible from the healthcare. So with this health education, patients are being educated on what are the limitations, what are the possible things that can be done, and what are the advances in that. Then again, there are barriers to the effective patient's education. Example, like lack of time. We know how our healthcare is being stressed up these days. So sometimes time may not be suitable for us to educate all our patients appropriate. Then confidence. Sometimes we may not be confident enough to do that. And motivation, working in a harsh environment without salaries, with so many issues to take care of, with so many tariffs coming, So one may not be motivated to do that. Scheduling problems again, that also affects inadequate knowledge from the healthcare personnel. Sometimes the healthcare himself need education on certain things that he may need to educate a patient. So inadequate knowledge, you can't educate somebody without having a knowledge on that. Environmental barriers like maybe noise, maybe crowded place, maybe non-convenient, and some other things like that may pose maybe even transportation. So hearing and visual problems. For somebody that has hearing difficulties, you may not be able to communicate verbally. You may need to employ somebody that understand and able to demonstrate for them. So that's pose a barrier to effective or visual problem. Somebody may not be able to see what you can demonstrate to them. So you have to depend on verbal communication. So how to ensure that learning has taken place? Reinforcement. Okay, there is one adage that said reinforcement may teach a donkey. So reinforcement is very vital. It repeats repeating what you said in simple, another form, another language, another way, practical demonstration may reinforce that. Then retention. Retention is also very important. It helps if you ask the patient to recap, it helps him to retain the knowledge, and also you are assessing how much you've given to him. Then motivation and transfer. Thank you for listening. Thank you, everyone. Comments is highly needed, appreciated, clarifications and comment. Thank you very much. Maybe somebody needs to moderate, please. I can't.
Dr. Hato, I thought he was moderating.
Okay. Dr. Dalhat.
Dr. Dahato, please.
Okay, thank you, Dr. Yahya, for the presentation. It's a nice one. So, Dr. Ike, you wanted to talk?
Yes, good morning, sir. Good morning, my teachers and colleagues. Thank you, Doctor, for the whole presentation. I think it was nice. I think you were able to bring out the information in the short period of time that you had. But I just have a few comments. One of them, it sounded like a set of instructions you were just giving to your patient. There was actually no empathy to it. Okay, I feel you just gave somebody a diagnosis that he's positive for tuberculosis. Most people outside here feel tuberculosis is like a death sentence, like it's killed people before, so am I going to die and all of that? You had a good simulator, because most people feel it's a death sentence. So if the man is before you, I just feel you should maybe ask him, sir, do you know the result of your saliva test? Because most times they may not really know what it is. And then you can quietly say, it came out positive for tuberculosis. Then you give him maybe a little bit of seconds to like get it that there's something wrong with him. Then you can go ahead to say, would you like me to tell you about it? What do you know about it? Would you want me to tell you? Do you want to know everything, or should I just tell you a few things about it? I think it shows more empathy than, I know most times we're anxious, but I feel ethics is communication if we look at it as our own patients in the ward. So we should at least employ some form of empathy to it when discussing with him. And then I felt you spoke for too long before asking him, do you understand? Okay, I just feel it's a two-way thing. So when you talk a little bit about it, maybe tell him it's caused by a bacteria. You can get it from breathing the same air with somebody that is coughing, that has this disease. So are you with me? Do you follow? Do you understand? Do you have any question at this point? Do you understand? So that he goes along with you. But I think you spoke so long before, and then you say recap. I think first of all, you should say, do you understand? Do you have a question? Then I can ask, okay, fine, if you understand now, then you can recap. Okay, but if it's for the information was apt, you did it well, you told him basically everything he really needs to know about it. I just feel the empathy, and then sometimes you veer up to very highfalutin words, then you come back, but I just feel the empathy we could do better with the empathy. Thank you, doctor.
Thank you very much, Ma. I really appreciate everything. Ma, regarding the first comment, me and my simulator, we agreed that he has already been told about that his sputum carries positive for tuberculosis. However, as you said, I will have show some empathy despite that. Because if I will have to start breaking the bad news, then continue, we thought the time may not be enough for you. But that's why we agreed with him that he has an idea. He was told that he has positive. So I will concentrate more on the risk posed by the disease. Thank you. However, all the comment, Ma, is appreciated. I should have shown some empathy for that. Thank you very, very much, Ma.
Okay, thank you for that. Dr. Momodu said he was querying empathy was not mentioned, just like she highlighted. Then Dr. Olalekan said, good morning. Thank you for the presentation. I think it will be good to find out what are the possible risk factors for the disease and address this in the treatment plan. Also monitoring symptoms and sputum tests for improvement, considering the index patient has been coughing for about 3 months. Is there any recommendation to screen or treat the relatives who are at high risk? Considering the low socioeconomic status of the patient, admission into the hospital may put financial burden. Is there any other way to address the issue of living in a room apartment? Thank you. So he's asking, is there any other ways to address that issue?
Other ways are if maybe in the area she has somebody that can help to give her either a relative to give her a room that she can be with for a certain, especially for the first 2 periods when the disease is having high chance of transmission. So that will help. And I asked her whether she can do that. It's like she shuts that door up, closed. Another thing again, only use of barriers and adequate medications. If you adhere to medications, you follow cough etiquette, and every member of the family use face masks. I think even if they stay together, the risk is reduced compared to not doing those etiquette. So that's what I can say.
Okay, the screening.
Yeah, we may also need to, because some of them, they might have already developed the disease even. So if they develop disease, they need to be evaluated and cured for that. They already have the disease. So that risk may not be there because they already, but if they don't have, that's when we'll be more aggressive and consider giving them prophylaxis. I wanted to update myself on the current, I even wanted to call you, Dr. Dalhatu, about the current update on treatment or prophylaxis of contact of smear positive, gene expert positive TB. But with a lot of schedules, I could not do that. So maybe you can help to tell us whether we go ahead and give them medication or we screen and give prophylaxis. I don't know.
Okay. Thank you, Dr. for the response. So the individuals that are considered for, you screen everybody in the family, the significant contact. The significant contact are defined as individuals that stay with the index patient for at least 8 hours in a single roof. Those that doesn't have the disease, if they are HIV positive, or if they are less than 5 years old, those are the category of individual we offer them latent TB prophylaxis. So we treat them for latent tuberculosis. But other ones, you just explain to them and they continue to take care of themselves. And then one of your response for the face masks, surgical face masks only limit the transmission of the disease from the person that have the disease. So individuals who want to prevent themselves from having the disease, they don't need to wear surgical face masks. They rather use N95 masks. So it's not usually encouraged. Whom I encourage to use face masks is the patient that have the disease. Thank you.
Thank you very much, Chief Talat. You are not been around closer. That's why I think if Haibin, you are in the hospital, I look for you actually to ask you for this information. Thank you.
Okay, no problem. Dr. Tito.
Good morning. Thank you very much, Dr. Yahaya and Dr. Dahatu. I have a few comments about the station, and thank you for the attempt. My first question is about a statement you made about culture in the question. So I don't know if I'm getting it correctly, but you told the surrogates that your sputum has been cultured and it's positive. I hope I'm not getting it wrong. And this suggests that the chances of transmitting it are higher. So it's a question. So I don't know, the culture or AFB is not mentioned in the question given, only gene expert. So are we allowed to add that to the scenario, really, like in cases of ethics? Also, for Dr. Dahatu, since he's the infectious disease specialist, now, does culture, a positive culture, really signify a higher transmissibility in TB? I thought it was really the AFB. I need clarification. And secondly, for the for this patient is a 35-year-old woman, so she's a woman of childbearing age. I'm just wondering if it would have been good to explore pregnancy somehow, whether subtly or not. Thank you.
Thank you, sir, for this question. Thank you very much. For the first question, you said is a slip of tongue. Actually, I should have said this sputum was examined and find out that it's gene expert positive. Sorry, it's really a slip of tongue. I shouldn't have mentioned culture. And yes, pregnancy should have been ruled out. But if we said we do everything, there are a lot of things. We shouldn't have finished by now. So I try to, but it's a very good thing to ask. It may add value to the treatment. And there are more other information that need to be asked. I just try to, I highlighted some few ones that maybe. And Dr. Dahatu could answer the question you asked about him. Thank you. I should have noted all those things that you mentioned. I shouldn't have mentioned culture. Maybe sputum was examined and it shows what we call gene expert positive. Thank you.
Dr. Yahaya, just before you hand over to Dr. Dahatu, before enough, I was waiting to ask you that question Dr. Asekeme did. That question he asked is a very vital question. There's nothing like there was no time. Once there's a female before you, you must ask, what if the woman was pregnant already? You could have, it has changed everything about patient management. Do you understand?
Yes.
You never can tell. It will change a lot. It will change a lot. And if the exam, because we don't know, is a recall. If the person did not go in this direction, the examiners know also, the simulator will not go in this direction. So we don't even know if the patient was pregnant. So if the patient was pregnant, that will now stimulate more questions. That will now make you go in the direction of that the examiner. And if that is the direction they are going, you earn more marks than if you are going in normal direction. Do you understand? So one time you see a female before you create a scenario with a female, please, as you're asking, I believe your name, or what's your name, your most important history. Please, are you pregnant? Always get that history before you dive in. And I'm happy that you and Dr. Dahatu you and your simulator practice before
Yes.
present. I think it made you guys load better. But
Yes.
remember, once a female, always ask, please, if it's a childbearing, please, or except it's postmenopausal, then once it's childbearing, always ask, ma, please, when did you see your last period? No, are you pregnant? When did you see your last your period? Thank you.
Thank you, ma. Noted, ma. Thank you very much for this contribution. Thank you, ma.
Chief Shitu, sir.
Oh, good morning. Yes, good morning, Dr. Dahatu. Good morning, Dr. Yaya. Good morning, Dr. Christabel. Just to reiterate what Dr. Christabel said and then make another comment. Yes, it's important to find out everybody of childbearing age in any counseling station, health education station, history station, whatever it is the station is about. It's always good to find out about their reproductive history. Okay? So, and sometimes it will just be difficult to ask the patient, are you pregnant? The person may not, may be told not to answer that prompt. They say, I don't know. Okay? It's easier to build it up. Oh, how many children do you have? How old is the youngest one? Oh, are you not planning to have any more kids? Or are you still planning to have more kids? The person say, yes, we're still planning to have kids. Okay, so you're not on any family planning. The person will tell you no. Okay, I mean, you've been seeing your period regularly, and I believe you saw it, you've seen it within the last 1 month, and questions like that will just basically make you come up with a conclusion whether the person may be pregnant or not. Okay, so they may be prompted not to answer you to say, oh, are you pregnant? The person will say, I don't know. So it's better you build it up in that manner. My other comment is to Dr. Yahya. You sounded very mechanical. You went through the motion, but it was too mechanical. Okay. Now, I always tell people that look at what the brief is at the station. The station task is to educate the patient. So you're actually being assessed on your ability to communicate and pass on information to the patient. Okay. And also, looking at how you pass on that information as per empathy and things like that. Okay. The knowledge behind the whole thing is not the bulk of the mark. Yes, it's a part of the mark, but I can guarantee you this: if you know how to educate somebody and you know very little about the disease entity, okay, you can pass the station. Okay. So, and please note, we are doing this virtually. We're talking over a virtual medium, and you're not there physically. You're actually going to be marked on both verbal and non-verbal communication. Okay, how your body language is, you leaning in to listen to your patient, you taking the time to pause to listen to what your patient happens to say. Okay, and things like that. So I want us to don't just think that it's just about saying it and then getting through it. No, your body language and how you communicate with the patient verbally and non-verbally is also being assessed. Also, try and give information in language that is at the person's level. This person said, I had not completed secondary school. So saying things like superficial and the rest, it is outside the wheelhouse of this of the person you're counseling. So try and break it down. There's something I usually do in the class where I tell someone to counsel me and I speak broken English throughout. Okay, and if you can counsel a patient in broken English, it actually eliminates all those terms. So if in the back of your mind, Okay, even though you're speaking in English, just say, oh, if I was speaking in broken English, would this term be appropriate? Okay. You know, in broken English, many times we describe what we mean. So for instance, in broken English, rather than saying superficial, I say, should I just tell you about, you know, the thing, small, just like, I mean, maybe go inside, where, you understand, right? And even to translate that to English, you can say things like, oh, would you just pick tidbits about this particular issue? Or do you want us to really go deep into it and bring out a lot of information? Okay, so the person will flow with you. So I just want to reiterate our ability to communicate is important. Okay, so when we do this, we practice. Please, many of us here are married and we believe we have spouses at home. What you do is just write a scenario for her or him and then let him look at it. And then you counsel the patient and see whether the person can, whether your spouse can flow with you. I use my wife a lot for those type of things, don't worry, when I'm preparing for exam. I just write it, I make many scenarios, try to pick out one, and then I just try and do it. If she gets it, then I know I'm doing well. If she doesn't get it, then I know I'm not doing well. So please, let's work on those other things that we can't work on here. So communication, verbal and non-verbal, please, let's try and work on that as well. So well done, Dr. Mohammed.
Thank you, sir. Thank you for addition, sir. They are all noted, sir. Thank you.
Okay, thank you, sir. I think Dr. Momodu also asked, TB is a disease of poor, although we now have it widespread due to increased travel, blue-collar job in rich areas. Say dot plus to end TB to stop TB. We are here to cover it. 2035 is already close by. I think this is just a comment. So, sorry, somebody asked me a question, but I can't remember the question. Or I think it has been trashed out. Dr. Tito.
It's already 7:40.
So I think, thank you, Dr. Yahya. Dr. Yahya, you can continue to uncle for the next presentation.
Okay.
Thank you.
Thank you, my teachers and my colleagues, for all the comments. I really appreciate, and I'll take note of them. I really appreciate. Thank you for that. I think we move to the next part of the presentation. It's going to be Dr. Ayodele. He's going to present question number 9. I believe he's in the house.
Good morning, everyone. Okay. Can I share my slides, please?
I personally can't see. I don't know.
Okay, so.
I can't see your slides, sir.
Can you put it in the platform if you have some difficulties, so that somebody may attempt to?
Okay, let me send to the platform then. So I've sent it to the platform.
Maybe somebody can help.
Okay, good morning, everyone. So I'll be taking question 9 of the National Postgraduate College November 2022 exams. So the question goes thus: 45-year-old man who is non-diabetic with a BMI of 35 kilogram per square meter, who had daytime somnolence and a diagnosis of obstructive sleep apnea syndrome was made. So the questions are: list 3 daytime and 3 nighttime symptoms, list 3 physical examinations to confirm the diagnosis, mention 2 investigations to confirm the diagnosis, and then how will you manage. Next slide, please. Okay, so the 3 daytime and nighttime symptoms, I listed quite a number of symptoms. For the daytime, patients could experience excessive daytime sleepiness and tiredness. Also have difficulty with concentrating, could be irritable. It could have headaches upon awakening. It could experience low mood. For personality changes, some of the patients' friends might have noticed that personality has changed. For nighttime symptoms, patients could experience frequent awakening during sleep. Could have a non-refreshing sleep, have choking sensation, enuresis and nocturia. The spouse might have noticed that the patient snores while sleeping. Next slide, please. So signs to confirm the diagnosis. So patients might be obese on a physical examination, and when you do the BMI as well. They might have a large neck circumference, usually greater than 40 centimeters. This is suggestive. Then they could have facial deformities as well that might suggest upper airway obstruction, and also micrognathia or retrognathia as well. When looking to the mouth, patients will have enlarged tonsils, you could have macroglossia, and it might point us to risk factors for upper airway obstruction. Could have a narrow oropharynx. You look at the nose, you could see nasal polyps suggesting some form of upper airway obstruction. Next slide. So to investigate this patient, 2 investigations to confirm diagnosis. One, overnight pulse oximetry could be done, and then would what we're looking out for is a decreased arterial partial pressure, saturation of oxygen less than 85%, or from baseline where you have it going less than 4% from the baseline. And also patients also do a sleep study or polysomnography. This is actually diagnostic of the condition. Okay, so the next slide. So how will I manage these patients? I haven't established a diagnosis of obstructive sleep apnea syndrome from the history, examination, and investigations. Management will depend on the severity of the condition, which can be assessed using the apnea-hypopnea index from the polysomnography. And patients could be classified as mild, moderate, or severe symptoms. Specialties involved in management of these patients will include primarily the respiratory physician, and however, there are also adjunctive specialties like the ENT. If patient has endocrine problems that might be suggestive of the etiology, patients might require the endocrinologist to be involved as well. If patient has acromegaly, hypothyroidism, obesity. Also, if patient has complications, because obstructive sleep apnea syndrome is associated with cardiac and neurologic complications as well. You might need to involve the cardiologist. If patient has hypertension, coronary artery disease, arrhythmias, and then if the patient has pulmonary hypertension, you also need to involve the respiratory physician as well. So essentially, the primary physician will be the respiratory physicians with adjuncts as well. The goals of management will be one, we need to educate the patient about the condition, the likely etiology and risk factors, and then going forward, the different modalities that would use to help the patient manage this condition. Also want to ensure that we relieve the symptoms, essentially the daytime sleepiness to nighttime symptoms from the obstruction, and to also improve the patient's quality of life as well. Also needs to address the etiology and relieve the obstruction. So in this particular patient, obesity appears to be the likely risk factor for this obstructive sleep apnea. We also need to prevent or manage complications and comorbidities. So if the patient has got comorbidities, if he's got or complications, if he's got hypertension, we need to manage that as well. If he's got coronary artery disease, he's got arrhythmias, he's got a stroke, depending on whatever might come up, we need to also manage this as well. So what are the modalities that we use to manage these patients? It could be non-pharmacological or lifestyle. which will include things like weight loss in these patients. Also, we need to avoid sedatives or alcohol if patient takes them. The likelihood that patients will want to take sedatives because they're not sleeping so well. We need to advise against that as well. And also the sleeping position, to advise patients not to sleep on their back. Usually, some say that you can have vests with like a ball at the back that prevents patients from sleeping on the back. This might help to relieve the upper airway obstruction at night. Also, the non-pharmacological devices that we can also use as well to keep the nasal management of the severity. Hello. Okay, so if you have mild disease, would encourage lifestyle modalities, like I said, weight loss, sleeping positions, awareness of alcohol, inclusive of dental devices or nasal continuous positive airway pressure. For moderate disease, the patient will require the nasal continuous positive airway pressure in addition to lifestyle modifications, and might also require surgery depending on the etiology. So patients could require tonsillectomy or some uvulopalatopharyngoplasty as well. For severe disease, in addition to the lifestyle management and the nasal CPAP, patient could also require surgery. In extreme cases, they might require tracheostomy. So moving on, I'll just talk briefly about with this outline. So next slide, please. So it's defined as complete sedation of breathing for greater than 10 seconds during sleep, despite continuing respiratory efforts. As compared to hypopnea, hypopnea is not complete sedation, it's just a decrease in the airflow, usually about 20%. As compared to central sleep apnea, where you don't have continued respiratory efforts. I mean, in obstructive sleep apnea, you have continued respiratory efforts. And then obesity hypoventilation syndrome, that one occurs during usually during the daytime. Most patients are asleep, and the patient is actually hypoventilating and not apneic. So like I said earlier, it's classified based on the apnea-apnea index into mild, moderate, and severe. Mild, if they have about 5 to 15 episodes, apneic episodes per hour during sleep, during polysomnography. Moderate, if they have 50 to 30 apneic episodes per hour, and then severe if they get greater than 30. So next slide. So epidemiology, some studies have said that 24% of the general population actually have obstructive sleep apnea. Of course, this will differ in specialist clinics where the prevalence might be higher. The male to female ratio is 2 to 1, and is set to increase generally with age, usually seen in middle-aged adults. It's set with obesity, and usually you have other comorbidities and complications. It's important. This topic is important because of the patient's decreased quality of life, concentration at work, has social disturbance. Could also result in traffic accidents because patients might sleep off while driving, and also is a risk of sudden death during sleep. So it's a quite important topic to note. Next slide. So the HA pathogenesis usually is a risk factor or etiology for upper airway obstruction. Like I mentioned earlier, you could have nasal polyps, rhinitis, you could have macroglossia, obesity, yeah, and then this risk factor, when patients then sleep, usually in the REM part of sleep, where the muscles are paralyzed, this can lead to paralysis of the upper airway, leading to complete obstruction. And thus, you don't have oxygen going down to the lungs. The patient is hypoxemic. Hypoxemia results in stimulation of the cardiorespiratory center, activation of the nervous system, and then this triggers the heart, the tachycardia, patient's blood pressure could go up, and then this this causes the patient to wake up, disrupt the sleep, the cycle recurs again and keeps on going on for a long time. When patient wakes up, patient doesn't feel refreshed because, of course, patient has had to have breaks in his sleep several times. Patient has daytime somnolence and all the other symptoms that patient has, like I mentioned earlier. Next slide. So the symptoms, like I said, daytime and nighttime, I talked about earlier, and then the signs as well. I'm not going to go right again. Then next slide, please. So, like I said, complications, patients could have cardiac arrhythmias. Like I mentioned, as part of the pathophysiologic mechanism, you have stimulation of the sympathetic nervous system. So patients could have arrhythmias, patients could have hypertension, coronary heart disease, coronary artery disease, and worst case scenario, sudden death while asleep. For neurologic, they could also have stroke as well. They could have psychosocial issues, can't concentrate at work, so has work issues. They could have marital strain. They could have traffic accidents because they could sleep while driving. Then they could have decreased libido as well. For the renal, like I talked about earlier, they could have enuresis, they could have nocturia, and this is usually because of the increased release of HL natriuretic peptide while asleep due to all the frequent awakening and stimulation of the sympathetic nervous system while asleep. So for the endocrine complications, it could be associated with impaired glucose tolerance in children, growth retardation, and of course low libido, like I mentioned earlier. Respiratory complications like pulmonary hypertension, respiratory failure, usually type 2 respiratory failure. Then if they're going for surgery that will involve the use of general anesthesia, or if they have to be sedated, there's a risk that they could have peri-op or anesthesia complications as well. Next slide. So the investigations, like I said, you need to do an overnight pulse oximetry. The SpO2 less than 85% or 4% decrease on baseline is suggestive. There are other conditions where you could have hypoxemia while asleep and might not be obstructive sleep apnea. Patients with COPD could have this, and patients with some neuromuscular conditions could also have this as well. The other test you need to do will be polysomnography. These are diagnostic. You can also do ancillary investigations to determine the etiology. So if you are thinking of acromegaly or hypothyroidism as possible causes, if you think of the goiter, so these are all things that you could do to evaluate. And then for complications, you might want to do an ECG, want to do an echo, all of those things, depending on what you think the complications as a reason is. Next slide, please. So how do we make a diagnosis? You need to have a suggestive history, supportive examination findings, and confirmatory investigations, usually the overnight pulse oximetry, and then the polysomnography. There is a score termed the Stop Bank score. It's a screening questionnaire for that will suggest patients could have obstructive sleep apnea, usually used by the anesthesia peri-op period. So the letters are just S stands for snoring, T for tiredness, O for observed apnea, P for blood pressure, B for BMI greater than 35, A for age, and then N for neck circumference greater than 40 centimeters. The next slide, please. So this slide just shows how to interpret the Stop Bank questionnaire. So patients could, so to the left, okay, thank you for enlarging. So to the left, patients could be classified as low risk, intermediate, or high risk, depending on what the patient's cause. So each parameter has one score. Now, if patient has 0 to 2, that's low risk. A patient has greater than 5, because that's high risk. Now, in between, where you have 3 to 4, that's intermediate risk. So to the right, how do you go about it? So first, you answer the questionnaire to the patient using, that's step 1. So if patient has greater than 5, because that's high risk, you need to go and do confirmatory tests for obstructive sleep apnea, maybe polysomnography or overnight pulse oximetry. If patient scores less than 2 or less, that's low risk. Now, the intermediate risk is where they have between 3 and 4. So what do you do in those patients? So you go to the, you can go 2 ways. One, when you look at the top part of the question, if patient has 2 or more scores and patient is male gender, if patient has 2 or more scores and has BMI greater than 35, and patient has 2 or more scores and the next one greater than 40. That's the bank part of the questionnaire. So these patients are termed high risk, and you should evaluate them for obstructive sleep apnea. So that's all essentially. Thank you. As my final slide. Management. The next slide is management. Is as detailed earlier. I wouldn't go over it again. Thank you.
Thank you, Dr. Ayodele, for this very good presentation. Thank you, thank you. We entertain contributions, comments. Thank you, well done. From the chat box, Dr. Ijoma Injonuka said, will modafinil be useful in the management of this patient? And Dr. Temitope want to say something. I think let him first answer this. Will modafinil be used in the management of this patient?
Yes, I mentioned that under the modality management modality, as a pharmacological, you could use modafinil as a CNS stimulant, could help with the daytime tiredness. So that's an option as well.
Okay, thank you. Dr. Temitope want to say something. Go ahead, Dr. Temitope.
Okay, good morning, teachers and colleagues. Thank you very much, Dr. Ayodele, for the detailed discussion on OSA. I just wanted to add a few things. So firstly, in the evaluation, it's important to carry out an objective assessment of excessive daytime somnolence, because when you do the sleep study or based on the stop-Bangor history, it is when there's additional daytime somnolence or daytime symptoms that it is referred to as OSA. So if you just have the obstructive airway hypoxias alone with obesity and other things, then it is just OSA. So usually it's important to assess, so apart from the history of fatigue and other things, to carry out an objective assessment of excessive daytime somnolence, either by using the Epworth sleepiness scale. There are other ones, Stanford sleepiness scale, but the ESS is quite, it's questionnaire is quite easy to give to the patients to answer. So usually a score of 10 and above, out of there are 8 questions with different 8 scenarios, and then the grading is from 0 to 3, so a maximum of 24. And so any score of 10 and above in a patient is suggestive of excessive daytime sleepiness, and that is an objective assessment that should be documented. So this is now combined with the other assessments in determining treatment plan. Then I'm not sure of the scenario, but I think an essential test here is arterial blood gas analysis, because this is required if you want to make a diagnosis of obesity hypoventilation syndrome, which is a hypoventilation syndrome. And by definition, usually any kind of condition that causes hypoventilation will give an elevated partial pressure of CO2, which is what the ABG helps us to assess, as sleep study will not assess this. So in patients that are obese, especially those that are like morbidly obese or have severe OSA on assessment on sleep studies, important to do their daytime ABG to assess for that. It's important because treating the OSA, even for OHS, we still treat, the initial treatment is still with CPAP. However, those that have OHS, it's important to keep in mind that the CPAP may not be enough. They may actually need more of a ventilatory support. CPAP is not a ventilatory support. Well, technically, it's more, well, improves oxygenation, and then for OSA, serves as a splint to keep the upper airway patent. But in those that have OHS, you need a support that would help them to blow off the CO2 that is accumulating. So they would need some form of non-invasive ventilation in some of them, which is usually given as bi-level positive airway pressure. Then in terms of the non-pharmacological, just to be clear in discussing with the patient, so weight loss is essential, and usually patients are able to lose about 10 to 20% of their baseline weight over 6 months to 1 year of therapy, then that can help in being able to, a possibility of them being able to go off CPAP therapy, because usually patients are concerned that are they going to be on this treatment for life. So usually if the risk factor in the patient is majorly obesity, and if that is addressed, then there's a chance that they can be weaned off the CPAP therapy. Thank you.
Thank you, Dr. Temitope, for this wonderful addition. Thank you once again. Okay. Dr. Omoko said, good morning all. Please, is CPAP a lifelong treatment? Also, how long should the patient wear the CPAP mask per day? All day or or only at night or when asleep? He wants clarification on that.
Okay, so for those on that's why I talked about the weight loss. So from the initial diagnosis, it's a long-term treatment. I would not really say lifelong, but long-term treatment. So how long it will be depends on other factors in the patient, especially the weight. So most times, patients with obesity that also have OSA or other things, usually it increases their, how do I put it, then benefiting from bariatric surgery if other factors are considered. So whatever the treatment modality for the weight loss, if they're able to lose 10 to 20% of their baseline weight, so it doesn't matter the weight, it's about the percentage, then usually in this category of patients, studies have shown that they can go off the CPAP treatment. So that's what is, and of course, there are some patients that have some other upper airway abnormalities that may be surgically corrected, that can also lead to them going off the CPAP treatment. So, but the essential thing is the upper airway dimensions. So, and then some studies are now showing that even those that are on CPAP for long, for maybe about 5 years or above, that in a way, the CPAP causes a little bit of some remodeling of the upper airway anatomy, that there's a possibility that even without the CPAP therapy, the symptoms will still not reoccur. But right now, for all intents and purposes, the treatment for OSA with CPAP is long-term. Then in terms of, so there's something called adequacy or optimal treatments when patients are on CPAP. So usually they should use it for a minimum of 5 hours, minimum of 5 days per week. So that is what we use to assess adherence or the quality of the treatment. So the patient should use the CPAP therapy when they sleep, not necessarily, well, at night for a minimum of 5 hours and then 5 days a week. And then also every time they sleep, actually. So it's not just nocturnal. So even if they want to sleep during the day, they should sleep with their CPAP. But for objective assessment of adherence and quality, usually we stick to using nocturnal hours, minimum of 5 hours, and then minimum of 5 days per week. And usually this is part of what we interrogate when the patient comes back with their device, and we have to check that on the machine. Then somebody asked about modafinil. And yes, Dr. Ayodele already responded that yes, it's beneficial. Well, it's important that it's actually the CPAP should help with the daytime somnolence. And then in the few patients that still have persistent daytime somnolence despite adequate and optimal use of the CPAP, yes, so some neurostimulants can be used like modafinil. Thank you.
Thank you, Dr. Temitope. It seems like you are a sleep specialist. Thank you for all this addition. Thank you very much. I think we can hand over to Ma, Dr. Christabel. Ma, go ahead, Ma.
Okay, Dr. Yahaya, thank you. Thank you for anchoring. Thank you for the presentation. Dr. Ayodele, thank you. It was quite lucid. We spent quite some time. I want to appreciate all our facilitators present. Dr. Atta, our dear class chair, thank you for coming to class. Chief Chitu, sir, please help us round up the class. Please stay in class. In class. Chief Chitu, sir. Dr. Chitu. So thank you everyone for coming to class. We'll meet again tomorrow. If there will be any, I know tomorrow is an Eid celebration. Tomorrow and next is Eid celebration. But I think 1 hour won't do much, just a little sacrifice. So thank you everyone. We'll meet in class tomorrow. Thank you.
Hey, Christabel, I think it's next tomorrow and Thursday.
I saw
Hello?
Tuesday and Wednesday.
Oh, okay. Okay.
The news they sent to me is Tuesday and Wednesday. I'll post it on the group later. So thank you everyone. I appreciate your presence. But it doesn't change. 1 hour doesn't change, except our brothers said no. They don't want to celebrate. No wahala. Dr. Yahaya, let me know if there's any change in plans, okay?
Okay, ma.
Thank you.
Thank you, ma. Thank you.
So we'll meet in class tomorrow. Have a nice day, everyone.
Thank you.
Thank you.
Thank you.